Hello, everybody, and welcome to today's virtual resident education lecture series. The topic is brain tumor management for the neurologist, from basics to brand new approaches. All participants are muted. If you're having any technical difficulties, we recommend disconnecting from the webinar and reconnecting. All participants are muted. If you do have any questions, please use the Q&A feature on Zoom, and we will answer them throughout and after the lecture. I am happy to start this by introducing Dr. Danielle Weber for being our Q&A moderator today. Thank you, Dr. Weber. For one of our first hosts, I am pleased to introduce Dr. Roy Strowd, an associate professor of neurology and neuro-oncology, an interim vice dean for undergraduate medical education at the Wake Forest University School of Medicine. As a researcher, his background in neuroscience provides a neurocentric approach to neuro-oncology and translational research. His research is advancing the field of neuro-oncology by discovering new treatments for glioma and innovations to improve the quality of life for patients with brain cancer or inherited tumor syndromes. As an educator, his mission is to inspire each student to find their passion and pursue it. He is the chair of the e-learning subcommittee for the American Academy of Neurology and is the current editor for the Neurology's newest journal, Neurology Education, which publishes original research articles in health professional education. Accompanying Dr. Strowd is Dr. Alex Gerhardstein. He is a PGY1 adult neurology resident at the University of Rochester Strong Memorial Hospital. He graduated from Wake Forest School of Medicine in 2023 with interests in medical education and neuro-oncology. He received a Bachelor of Science from Wake University in biology, focusing on oncology coursework. Alex originally hails from the town of Hawthorne in Northeast New Jersey. He enjoys spending his time at the Jersey Shore with his family, participating in outdoor activities such as hiking, lacrosse, and cooking his family's traditional meals. Dr. Strowd and Dr. Gerhardstein, we are so excited to have you here today. I am turning this all over to you.
Fantastic. Well, thank you so much for having us. I think Alex wishes he was at the Jersey Shore, but he's an intern, and so in the midst of the medical ICU. And so, Alex, great to have you here. I'm excited to be here, and thanks to all the attendees. We're really excited that we were invited to talk about brain tumors. We have a lot to go over, but really want to provide an opportunity for you all who are attending currently to ask questions and to learn about brain tumors and get excited about what we're doing. So, Alex, I'm going to share my screen, but I'm so excited for you to be here. And I think everyone can see my screen. And so I have a few slides, a number of slides that we're going to go through. And Alex and I are going to try and make this as interactive as possible, as that we can in a webinar. And we want to hit a few things. We're going to talk about brain tumors and brain tumor management. We're going to take the neurologist approach to that. We're going to start with some of the basics and just review, kind of what are brain tumors, what type of brain tumors do we see, how is the care of a brain tumor handled, and then get to some exciting brand new approaches, new things that are kind of revolutionizing the field. And there are opportunities for questions all along the way. So Alex will have some questions, and he'll be asking, me and us some questions as we go, and perhaps kind of planting the seeds in your all's mind who are attending today of questions you have. We want you to be thinking about brain tumor patients that you've seen, and brain tumor questions that you've answered, brain tumor, challenges that you are thinking about, and bring those into the Q&A. And so please do provide those, and there'll be opportunities to pause along the way and explore those. So with that, let's dive into it. We have no disclosures, Alex and I, related to this talk specifically, and we'll be talking about a number of things just related to brain tumors and brain tumor management. Before we dive into it, I did want to let you know about an exciting partnership between VRELS and the NeuroPanels. Ben did mention I am the chair of the e-learning subcommittee, and e-learning has set up a new e-learning approach. It's an interactive learning webinar called NeuroPanels, and it's exactly that. It's a panel of expert neurologists talking about a topic, and we've partnered with VRELS, and our upcoming NeuroPanels will be on neuro-oncology with two great colleagues, Schaff, Nimish Mohile, talking about two challenging cases in neuro-oncology. So I'm going to challenge you all to take the knowledge you get over this next 50 minutes or so and take it into those cases and and pepper Dr. Schaff and Mohile with questions that you have related to those cases. So put that on your calendars, and I hope you can join. And now we're going to dive into it. So we're going to start with listing the most common brain tumors and their relative frequency. And I think that will be helpful. Things that are common are things that you as a neurology resident want to know about. So let's know about, kind of what brain tumors you're going to see and experience in patients. And then let's dive into understanding those. Then we're going to shift to describing the typical journey for a glioma patient. Gliomas are what we often see in the hospital, on the wards, as well as in your clinics. And I'd like for you to understand the epics of care for a glioma patient. And we'll discuss the role of the neurologist, and specifically neurology resident, in managing issues in that epic of care. So we'll try and grab one or two nuggets that happen at initial presentation and radiation and chemo and those sorts of things that you need to know as a resident. And then at the end, we'll try and save some time to identify new exciting therapies that are changing kind of the landscape of care for brain tumors. All right, so first section is types of brain tumors. And I was going to put all the attendees on the spot, but we can't because there's no chat. So Alex, I'm going to put you on this spot, and he doesn't even know this. And we're going to walk through some of the types of brain tumors that we see by imaging, because it's a lot of imaging that we do as neuro-oncologists. This is what makes the job really fun and exciting. We probably look at more MRI scans than even stroke docs. And this is really the beginning point of a lot of the work that we do with patients. So here are a number of brain tumors, and our goal today is to deconstruct this. So in your mind, when you see a patient, when you're sitting down looking at that MRI scan, well, what is this brain tumor? What is the treatment? What types of things are going to be encountered by this patient? And, how am I going to address those? So I didn't tell Alex I was going to do this, but Alex, let's run through and just we'll do a pop quiz, and I appreciate your willingness. And we'll kind of think about, well, what are we looking at here? What types of brain tumors pop into your mind? So Alex, as we look at this top right, MRI here, and I think everyone can see my cursor, attendees, what are you thinking at when you look at this? Alex, what are you thinking about? What's this brain tumor? What comes to mind?
It's fairly large, and it looks like it's enhancing. I think of like some sort of high-grade glioma.
You are spot on. This is what we're all thinking about, right? Big, a lot of mass effect. And what we'll talk about when we get to imaging is that enhancement pattern. And enhancement really guides us when we're looking at an MRI of the grade, the aggressiveness, and prognosis. And one of the things that you're seeing here is this is inside the brain parenchyma, and that guides us to what type of tumor to think about. And glioblastoma is going to be top on that list. Yeah, let's compare that to the one down here, bottom right. What are you thinking about here? What kind of stuff jumps out to you there?
I believe that's diffusion restriction, and it looks kind of diffuse, not as well circumscribed, maybe like a low-grade glioma.
I'm loving this. And I didn't tell you, this is actually the flare. It looks a lot like diffusion sequence as well. But and I think you're calling out those key features is what we'll talk through as we think about gliomas. Is they are diffuse, they're infiltrating, they get into the brain. It extends even beyond this area of white. So it could be an infiltrating low-grade glioma, and we'll get back to that enhancement pattern. The differential may be HSV encephalitis too, and sort of bringing in all that other knowledge that that you all have. So that's great. Those are two common kind of sporadic brain tumors. This one's interesting. How about this one next to it? We're looking at a bunch of things. You got this thing here, something here, something here. Any things that are coming to mind as you look at this thing here, kind of reactions to that one?
Well, we're at the level of the brainstem. I see a large mass coming off of the brainstem. Is it like a nerve sheath tumor?
Loving this. Yeah. So this is the fourth most common brain tumor that we see, a vestibular schwannoma here on the left and here on the right. And here, kind of back here, a meningioma next to the brain. So now we're thinking, God, why does this patient have multiple tumors? That's a multiple tumor syndrome. This is probably neurofibromatosis type 2. So at the end, we'll talk about some of these new treatments. Not a few brain tumors are inherited. Most are sporadic, like the glioblastoma we looked at the right, and the low-grade glioma we looked at the bottom right. But we do see inherited tumor syndromes, and want to think about how we consider those patients and how we treat them. So maybe last one here is this one really jumping out to us in the middle. It's pretty it's one of those wow, kind of this is an interesting scan and probably a problem. Anything jumping out in your mind as we look at all of these kind of dots, all these homogeneously enhancing things going on here? What do you think?
Yeah, so it's bilaterally, it's small lesions, it's towards the periphery. Is it metastatic disease?
Great point. We're seeing gray-white junction lesions also on the cortical surface. So this is aggressive brain metastasis, possibly with leptomeningeal metastasis. And so not all brain tumors are primary brain tumors. The most common brain tumor is actually a secondary brain tumor, brain metastasis. And this is absolutely brain metastasis, a patient with breast cancer. So we're going to try and deconstruct this as we go through the lecture. Alex, phenomenal job. Love where we're getting started and kind of thinking on this. And where I'd like for you all to start is, just with the imaging. We're going to talk about the clinical presentation, but quickly these patients get MRI scans. And I think the first step in approaching a brain tumor patient and thinking about the types of brain tumors you want to consider, there's over 125 different brain tumors. But when you look at that scan, you can quickly narrow it down to kind of 4 or 5 things to consider. And the first thing I do is consider and think about and really name whether this lesion is in the brain or outside of the brain. And you can see that on the MRI scan. Clearly, this is a diffuse infiltrating, non-enhancing lesion within the brain. This is a brain parenchymal lesion. And if it's a tumor, we're going to think about that by cell type. The 5 cell types that kind of live in the brain, and the 5 tumors that are parenchymal-based tumors that we want to put on our differential diagnosis. That is contrasted to this vestibular schwannoma we just looked at. That's not in the brain, it's outside the brain. If we looked at the T2, there'd be CSF in between the tumor and the brain parenchyma, the midbrain here. That's clearly outside the brain. And those lesions that you see that are tumors that fall outside the brain, we can also group those into 5 categories, and we can do those by location. Meninges, pineal region, cella, CP angle, and then peripheral tumors. And so there's really only 5 things we're going to put on the differential as we start to look at that scan. And that can be helpful with breaking down that long list of 125 brain tumors into the kind of 5 things that we want to consider as we're approaching that patient. So let's dive into that just a little bit more. We can think about the tumors we categorize by cell type, and the tumors we want to think about by location. So just looking at that initial MRI scan can start to narrow down that differential. The cell types in the brain are astrocytes, oligodendrocytes, ependymal cells, the neurons. It's actually very rare to see a neuronal-based tumor. It's often why brain tumor patients don't have the types of symptoms you see in a stroke patient, because the neurons are normal. And the neuroepithelial cells, those primitive cells that exist in the brain. And there are tumors that are derived from each of those. The astrocytoma is the most common type of brain tumor, so we really want to know about that. That's followed by oligodendroglioma, accounting for the other 15%, and then ependymoma may be less than 5% of brain tumors. And that's the most common things that we see. They're all glial cells, and they're all glial tumors. And so we're going to spend some time today talking about gliomas. There are 2 other rare brain tumors that occur in or around the brain parenchyma, and that would be choroid plexus tumor and immune-related tumors like CNS lymphoma that we won't focus on. They're rarer, but need to be on that differential. So those are the things I want you to be thinking about when you're looking at an abnormal lesion that looks neoplastic in the brain parenchyma. If you see a tumor something that looks neoplastic in certain areas around the brain, outside of the brain, we think about those locations in the meninges. There are 2 things on the differential, meningioma and this rare thing, hemangioblastoma. So just knowing that location breaks that down. In the cella, there's 2 things we think about in the cella. That's a craniopharyngioma would be the most common, or a pituitary adenoma kind of sitting down within the region of the cella. So 2 things on the differential for a cellar lesion. In the pineal region, that area right above, the quadrigeminal plate, the pineal region, we think about 2 tumors that are on the differential for that: pineal parenchymal tumors and germ cell tumors. Those really rare but extremely treatment responsive germ cell tumors in the pineal region. In the cerebellopontine angle, there's actually not 2, there's 3 tumors we put on the list. We say amen in the cerebellopontine angle. So AMEN is the mnemonic for an acoustic schwannoma, meningioma, epidermoid cyst, and a facial neuroma is the differential for CP angle tumors. And in the nerve sheath, there's 2 tumors we put on the differential, a schwannoma and a neurofibroma. So also looking at the image and can guide us to the location and break down that long list of 125 different tumors into a narrower a list of tumors we need to know. And that can help us focus the rest of our lecture on what do we need to learn about? What do we need to focus on? And glioma is going to be at the top of that list. And then the last way I want you to think about the types of brain tumors are by their frequency. And so these 2 circles here give a pictorial description of the relative frequency of different brain tumors. half of the tumors that occur on the brain are going to be not primary brain tumors, but secondary brain metastasis. And of those, lung, breast, melanoma, and renal cell carcinoma are the ones you need to remember. Lung and breast are common brain causes of brain metastasis because they're common tumors. There's just a lot of lung cancer. There's a lot of breast cancer. And so those eventually, even though there's not a predilection for the brain, they head to the brain. Melanoma has a predisposition to the brain, and it shows up bright on the pre-contrast T1 and can bleed. And renal cell carcinoma also can show up in the brain and can bleed as well. And so that's how we think about those lesions on the brain. The other half of brain tumors are primary brain tumors. And we think of four most common tumors that we see on the brain: meningiomas, gliomas, pituitary tumors, and vestibular schwannomas. And what you're seeing in the colors here is three of those are actually benign tumors that are not a cancer. That's meningioma, pituitary adenomas, and vestibular schwannomas. And the cancer that we see is glioma. And we're going to focus on that because that frequently comes into the clinic. But the most common primary tumors that occur are actually, benign lesions that may be managed by a neurosurgeon, by an endocrinologist, or by other, ENT physician or other specialists, and neurologists may be called in certain kind of selected instances. So that's the first part of this kind of talk, the types of brain tumors. Alex, I think you have some questions about this, and maybe some questions about what I said as our attendees are thinking about questions they have. What are you thinking?
Yeah, so we kind of already answered the first question. That most common types of brain tumors are secondary. But for the primary CNS neoplasms, it's mainly the gliomas that we see the most as residents. Would you say there's a specific glioma? You said astrocytomas were the most common. Do you usually see like high grade or low grade more commonly?
This is a great question, Alex. I think this is something to think about. It's just, what are you going to encounter as a resident? And it really depends on where you are. In the inpatient setting, the gliomas that come in are often patients that are having seizures. Dan Weber's liking to hear that. It's the seizure patients that are really coming in, frequently. And that may be your low-grade glioma patients that could have a well-controlled tumor, but refractory seizures and may need to be considered for seizure surgery. Or your high-grade tumor patients who are coming in a crisis. The tumor's growing, seizure is a part of an impending focal neurologic deficit, and you're thinking about, referral to surgeons. So we certainly see those. In the outpatient setting, the neurologist is frequently following, those low-grade tumor patients. Large, high-grade lesions can cause seizures, but it's actually less common for them to be treatment refractory. The treatment refractory epilepsy patients that have a tumor often have a lower grade, lesion. And so that's where it's important to know, the kind of the imaging differences and some of those things we'll get to.
Okay. Next, just thinking about who to think about for these kinds of neoplasms. Who do you think about when you, what population comes into your mind when you think about brain tumors?
This is a great question. So 3 thoughts here. The secondary brain metastasis occur in cancer patients. So anyone you see with cancer, that's already something you're going to be thinking about. For the primary gliomas, meningiomas are more common the older we get. In fact, meningiomas and gliomas increase in prevalence with increasing age. So the older the patient is, the more likely that is to happen. And meningiomas have a female predominance. And so we think about those, as individuals age, and certainly in women a little bit more commonly than men. Gliomas are random. They are sporadic, and they can occur in any patient in any population with a median age of around 50. So we see them in young 30s, 40s, year old patients, as well as kind of 50s, 60s, up to 70 and 80. It really spreads the gamut, and often our glioma patients are otherwise healthy. I see your risk factors. We don't have a lot of risk factors for these tumors other than childhood radiation. These are things that just occur by chance without smoking or tobacco or cell phones or, other sorts of things that are clear predispositions, except for rare genetic syndromes that we'll get to at the end of the talk.
Awesome. Next thing would be, when you have a new patient with a brain mass, are there other things on the differential other than brain tumors that you want to think about? And how would you differentiate between those different types of brain masses? So are there things you look for and you say, this looks like CNS lymphoma, or this kind of looks like a small or a low-grade glioma?
This is an extremely important question. So I'd love for you all to kind of perk your ears to this, because just because you're looking at a scan doesn't mean it's a tumor. And we are looking for those other features to guide us. Tumors are mass lesions. And so often what I'm looking at on the imaging is not actually the lesion, it's everything around it. What's the ventricle doing? What are the gyri and sulci doing? How's it displacing the brain? Things that are outside the brain should have a CSF line in between the tumor, the lesion, and the brain. And that really helps me to know whether this is extra or intraaxial. And then if things inside the brain, we're looking for that, mass lesion characteristic. Tumors can be bright on D1, a DWI and diffusion weighted images, but often there can be some restricted diffusion, particularly with highly cellular tumors like CNS lymphoma and some gliomas, but it's not as prominent as, say, a lymphoma or certain other, tumor entities. And so we're using those imaging features to differentiate that.
Awesome. And you already mentioned a term, leptomeningeal disease, when we were talking about the cases. So this is a term I've heard a couple times, and I didn't really understand it at first. So would you mind describing what leptomeningeal disease is, kind of how you recognize it and how it changes things?
This is important because we're going to focus on the common things being common today in the rest of our talk, but we also need to know about the rare things, and that is leptomeningeal disease. This is spread of a systemic malignancy into the CSF space, which is often hematogenious, and it can occur as from adjacent spread from a lesion in the spine or the brain, but really it's typically a hematogenious dissemination of a systemic cancer into the spinal fluid. It's very difficult to diagnose, and we think about things like clinical symptoms, CSF cytology, and imaging features to raise suspicion. And in a cancer patient who presents with multiple cranial neuropathies, this has got to be high on the differential. And it's really important to diagnose because it can masquerade as other things. And the quicker you intervene, the quicker that management part of your question occurs, the better patients do. It tends to be a very difficult end-stage part of the cancer process for patients that experience it.
Got it.
Well,
Thanks.
those are great questions. I think there's a few in the chat. I may move us forward, and then Dan and Alex, you can bring some of those questions in as we go. For those that are listening, we want your questions, and so we'll kind of bend and flex the lecture as we go to respond to those. This is about sort of helping you, and guide your knowledge. But let's dive into the journey of a glioma patient, and I'm going to spend some time in some areas and less time in others. But I do want you to understand what happens to a glioma patient. You may have meningioma questions or pituitary tumor questions, and so we want to come back to those. But let's spend just a little bit of time talking about what is it like for the glioma patient, and what does the neurologist and neurology resident need to know to intervene. And we're going to break this down into these kind of 6 or 7 epochs of care. I want you to think about symptom onset. What's that initial presentation? What should you focus on at the initial presentation? I want you to know about the imaging and be able to kind of dissect the imaging a little bit and know how that helps you as a neurologist. And then I'm going to go very quickly through surgery, radiation, and chemotherapy. You don't need to know the ins and outs of that, but what should you be thinking about when the patient gets surgery, which is the initial kind of step, and then who are we doing radiation and chemo for? And then we won't talk a lot about recurrence, but if you have questions, we can kind of dive into that recurrence space. So we're going to break this, kind of cancer journey down into these areas. And we'll start with symptom onset. So I want you to pause just a minute. How does a brain tumor present? What are some of those things that you can think about in brain tumor patients you've seen? What are the ways that a brain tumor patient can present? How do we think about that? And Alex, I don't know if you can channel our audience here, and see what they're thinking, but what do you think? How do our brain tumor patients present? What do you all think?
Well, I think seizure is pretty common for an onset of brain tumor, a new brain tumor.
Read my mind.
Next would be like any neurologic deficit, just because it's in the brain and pressing on things.
Yeah, and this is tough because we often think, they could present with this, that, or the other, and it's all these different symptoms based on where the tumor is. It's really important when you're seeing these patients to group those things into, is there a neurologic deficit present or not? Because it kind of changes how we manage that patient. Patients with focal neurologic deficits do worse. Their prognosis is poor unless we can rescue those with surgery. So that's part of what we're thinking about with steroids and surgery and kind of the prognosis of the patient is this a focal neurologic deficit or not? Fixed deficits after surgery become a problem. So great way to call that out. Yeah, any idea on, there's one more I'm thinking of. What are you thinking?
Yep, I saw someone in the chat answered increased ICP.
Yes. Oh, I love this in the chat. That's phenomenal. So, headache can be seen, nausea, vomiting can be seen, headache can be seen with 1,000 things. What you're thinking about with those types of symptoms is there increased ICP? Because then your problem isn't the tumor, your problem is the ICP. And we divert our care to initially managing ICP, then we come back to the tumor. And job number one is to resolve ICP issues. And even if it's a lymphoma patient, if steroids are needed to manage ICP, that should happen up front. That's an emergency. And so we really kind of divert the tumor care for the symptom management of those patients, dissimilarly to how we would manage, say, a seizure or focal neurologic deficit. So yeah, when you're seeing that brain tumor patient, I want you thinking, is this seizure as the presentation, focal neurologic deficit, increased ICP? What bucket does it fall in? Because Dan Weber's here, though, I got to spend a minute talking about seizure with these patients and just dive a little bit into that part of the presentation. And here's some data on seizures in glioma. And there's a few things that you see here. So one is seizures are common, but they're not equally common across all of the grades. So that prevalence of epilepsy by grade, seizure is really common with the grade 2s. It's really common with the grade 3s, and it's only seen in half of grade 4s. And this is why we do not prophylax with anti-seizure medications in all glioma patients just because they have a glioma. We really treat patients for epilepsy if they have a seizure, and we don't prophylax or treat patients who haven't had a seizure unless they're around that perioperative space. This can also be prognostic. So in patients with a high-grade glioma, the presence of epilepsy is a favorable prognostic sign because it means they didn't present with a focal neurologic deficit. That was going to be a problem. This must be a slower growing high-grade glioma. It must be less aggressive because they presented with epilepsy and not a fixed deficit. And so that's prognostic. The presence of seizure is not prognostic for low-grade glioma patients. Those with seizures, those without seizures, they're going to do how they're going to do based on the genetics of the tumor. So the presentation alone can start to shape how this patient's going to do, how urgent we are in our management, and how we're thinking about that. So Alex, I think you had some questions on this too. Yeah, I think you were thinking about this.
Yep. And so just when you see a new brain tumor patient comes in with a scan concerning for a new mass, is this an emergency? What do you consider it?
So I break this down into those 3 symptom buckets. A seizure is not an emergency, and the brain tumor causing that seizure is also not an emergency. And sometimes if the seizure is managed, those patients may come in for their biopsy or surgery, or they may go home and get an outpatient, a follow-up, and that's okay. That's not an emergency. You treat that like any other seizure that you would treat. Can be managed inpatient, but not a requirement. A focal neurologic deficit is a new problem, and that's often an inpatient problem. And there would be a varying degree of whether that's an emergency or not, and whether it can be rescued with steroids or those things. ICP issues are an emergency. So that brain tumor causing an increased ICP presentation is an emergency. So that's where I like those 3 buckets to help me triage the patients I'm seeing in the ER.
Awesome. Next question would be, I've seen a lot of brain tumor patients on Decadron or dexamethasone for symptom management. I was wondering how you picked those patients that you used this and what would be the utility kind of in it.
Yeah, this is such a good question and really could take us a whole lecture, kind of breaking down the art of steroid use. This is really an art, not a science. And so this is where working with the folks in your area as you see these patients and asking this question and, kind of challenging them is helpful. There are some true isms that I think we can highlight, practice patterns. So dexamethasone is the steroid of choice for a patient with a brain tumor. It is highly potent. You can use a lower dose for a higher potency. It has less mineralocorticoid effect. So it tends to be good with brain edema and for these brain patients without a lot of drug-drug interactions. So that's why we use dexamethasone and not, say, prednisone or hydrocortisone or methylprednisolone or those sorts of things. That's one truism. You're going to see dex used for these patients. The second is we don't like Decadron if CNS lymphoma is on the differential diagnosis. If it's an emergency, manage the emergency. And if steroids are required, then you need steroids to do that. But if not, we like to withhold steroids to increase the diagnostic yield of the biopsy that's going to be needed to establish that diagnosis. And so that's when you see that consideration of holding steroids. In all other patients, brain metastasis, gliomas, meningioma, whatever it may be, we use steroids and we use it to manage symptoms, those focal neurologic deficits, controlling the seizure focus or nidus. This tends to be where we would use steroids even before surgery to help to manage that presentation.
And then there's two quick questions from the Q&A. So why is it that epilepsy is more common with lower grade gliomas? Do we have a good reason?
Great question. I don't know why this is, and there's a lot of science going into it. And there's two things I would point to, and I'd love you, whoever asked us, to help us research and explore this. But two things that you want to think about. So one is there is this zone of of excitability, excitotoxicity that occurs around a glioma. Gliomas actually interact with the normal neurons that are around a tumor to increase glutamate production. So there's glutamate excitotoxicity that occurs around the outside of tumors. And there are certain tumors, particularly those that have TP53 deficiency and others that have higher rates of glutamate production and higher peritumoral glutamate excitotoxicity that may drive tumors. And that may be more present in some of the IDH mutant lower grade gliomas than the high grade gliomas. So the biology and how the tumor interacts with the surrounding neurons may influence the prevalence in lower versus higher grade gliomas. That's one thing, the biology. The second is big brain tumors that grow quickly may just grow so quickly they present initially with their focal neurologic deficit, whereas the lower grade gliomas, they grow more slowly. They don't cause a focal deficit because they're growing in between the neurons. And then, finally, they present with cortical irritability. So it may just be the growth trajectory that's causing that difference in prevalence. Again, the glioma cells, you find them in between normal neurons. You do a biopsy, and it's glioma cells distributed around reactive astrocytes and kind of normal neurons. And so that may be some of the reason there. Great question.
And one more question based on our conversation about dexamethasone I think you mentioned it. Is there any concern that it may decrease your yield if the tumor is indeed a CNS lymphoma?
That is true. Now, and yes, it is true that you could decrease the diagnostic yield of a brain biopsy or an open surgery in a lymphoma patient who's been on steroids. That's pretty uncommon when steroids are initiated within 24 hours of the surgery. So, it's not like every drop of steroid is gonna cause a problem. If there's a big CNS lymphoma that's there, a little bit of steroids isn't gonna, rapidly, melt that away, rapidly, although they work pretty quickly. So we do worry about that. In patients who are on steroids, and we want to increase the diagnostic yield, often we'll wait 7 days after with the withdrawal of steroids, or we'll stop the steroids and you can repeat an MRI scan. And if you see a big lesion there, that can make you feel more confident about increasing that diagnostic yield of a patient going to surgery. So those would be some considerations about how to operationalize that for patients.
Awesome.
Great questions. So these are great. We're going to keep going to the next epoch of care, and we'll get to some of your other questions, as we get there. Please keep thinking about them and including them. I'll go through imaging, and we may actually go through imaging and surgery and kind of hit some questions after that. But imaging is important. It's where we started and where we want to think about, that after the patient presents with seizure, focal neurologic deficit, or increased ICP, we get an image, we get an MRI scan, and the CT may be done, but it's going to quickly lead to that MRI scan. And the thing that I want to highlight is how to think about enhancement. And I want you to think about enhancement. I'm not going to talk about the differential diagnosis or how to differentiate neoplasms from non-neoplasms. We'll need a whole talk about that, but I want you to know the enhancement pattern that we see. So if you're looking at a tumor and you think it's a tumor and it looks like a glioma, it's in the brain, how does the enhancement pattern already guide you in thinking about this patient? Well, there's 4 grades of typical gliomas, grade 1, 2, 3, and 4. That's not always true, but typically true. And we see different enhancing patterns. For grade 1 tumors, and the classic example of a grade 1 tumor is a pilocytic astrocytoma, they are enhancing. They're avidly enhancing. And here we're looking at a left optic pathway, a left optic nerve, a glioma, pilocytic astrocytoma. This patient probably has an F1, and this is an avidly enhancing nerve. The whole nerve is bulky and enlarged. It's all the mass, and it is avidly enhancing. And those grade 1 tumors have that under the microscope. They've got a lot of endothelial proliferation and Rosenthal fibers and all these things, and they're enhancing. They almost look higher grade, even though they're the lowest grade. And we often see those in children. This is probably a child scan because grade 1 tumors are uncommon in adults. If we move to grade 2 tumors, you actually go back to the kind of beginning. They don't enhance. Only 30% of these grade 2 low-grade gliomas will enhance. They're often non-enhancing T2 or flare bright lesions like you see here. This is a flare lesion showing an insular glioma, probably an astrocytoma or oligodendroglioma, and only 30% of these will enhance. As we move up in aggressiveness to grade 3, 70% of the grade 3 tumors will enhance, but often they have a different enhancing pattern. Rarely will they ring enhance, like we're going to see with grade 4 up there. Often it will be a patchy enhancement, an incomplete kind of heterogeneous enhancement, or sometimes they're homogeneous. Right before they're about to kind of get to grade 4, it's more of a homogeneous pattern. It's not really, really bright like your CNS lymphomas. It's not diffusion bright, avidly diffusion restricting like CNS lymphoma. It's almost just a fainter homogeneous enhancement like you see here, and 70% of these grade 3 tumors will enhance. So if you start to get an idea of the aggressiveness of this from the imaging, and over 95% of the grade 4 tumors will enhance, and not only will they enhance, they will ring enhance. This is a complete ring of enhancement to contrast the inflammatory kind of tumefactive MS or MS lesions that will have an incomplete ring of enhancement. It's a full white ring of growing, enhancing, infiltrating edge of tumor with a central necrotic core. So Alex, you have a couple good questions here. I may have you pause on these so we can get to kind of the next piece, and then we'll bundle all those questions on imaging and the kind of next step, which is surgery. But before we get there, I do want to hit a couple of things about imaging features that are important for prognosis, because we want to know about enhancement, and then we want to know on that imaging what really makes us concerned. And that would be a large tumor that's greater than 5 centimeters, a tumor that's bilateral, and you can see here the classic butterfly glioma, this lesion that's enlarging the entire corpus callosum. It's extending into both cerebral hemispheres. It's sort of having that butterfly wing effect around the corpus callosum, so it's present bilaterally where there's midline shift or multifocal. And actually here, for those that are a little bit more advanced, there's a difference between multifocal and multicentric. Here we have multiple foci of enhancing tumor, so that's multiple foci, but this is the accompanying T2 image. And so each area where there's an enhancing nodule, there's an accompanying area of flare change, but the flare is not connected. So this is not just a multifocused tumor, this is multicentric. There is 3 centers of tumor that are not connected by intervening flare, which is different from multifocal lesions where there's one area of flare and kind of multiple enhancing nodules within it. And each of those has kind of prognostic implications. So you did your imaging, and now you're going to move to surgery, and we'll talk just a little bit about surgery. We won't go into kind of gory details unless you have questions, but I want you to know the key parts. Why we do surgery and what surgery offers the patient, because we see this lesion on imaging and we need to figure out what is it and how we can get the best treatment started. And so we think about extent of resection, and we can also talk a little bit about alternatives to resection as we think about this. This is what I want you to know about surgical resection and surgical approaches, for patients with gliomas. We suspect it was a glioma. We did imaging to confirm that it looks like a glioma. What are we looking for with surgery, and what are you working with the neurosurgical colleagues on as you're thinking about this? There's 2 reasons to do surgery. One is to acquire tissue, and the other is cytotoxic reduction. So in all patients, we have to acquire tissue, and that could be biopsy, subtotal resection, or a gross total resection. Regardless of how we get that tissue, we need tissue. That's the #1 goal. And we use tissue to make a diagnosis. Diagnoses are only made by tissue. Tissue is the issue in oncology, and so we got to make that diagnosis. But we also want it for molecular analysis. In the next section, which I'll go over, molecular analysis is increasingly important in making a diagnosis. So we do gene sequencing to really know what type of tumor this is. And then this actually has therapeutic implications. We use the molecular analysis, the gene testing to guide treatment. So that's the most important thing that we do up front for these patients. And then in some patients, we consider cytotoxic reduction. That's removal of tumor or reduction of tumor volume. And I like to think about these two pictures. I'm not a golfer. I like to golf. And everyone loves the beach, including Alex, at the Jersey Shore, right? So we're thinking about the sand kind of sitting here. And when you look at the scan, I talk to patients, the scan looks like a golf ball just sitting in the grass, right? Yeah, you do surgery, you scoop it out, take it out, all the grass is kind of normal, and it goes back to looking fine, and the tumor's gone. And I think to patients, that's often what they see when they look at this imaging. And what we need to guide them for as we're having these conversations is that for diffuse gliomas, the gliomas that you see, it is not a golf ball in the sand, in the grass, it is the sand. It is an area where we're seeing the highest volume and intensity of tumor cells, but the sand extends well beyond the area we can see. The tumor cells extend well beyond the area that we see. And so surgery is important for reducing the bulk volume. But there will be residual tumor cells around that area of surgery that requires therapeutic implications and interventions. And so even in those gross totally resected lesions, there is additional infiltrating edge of tumor, fingers that stick into the normal brain, sand that is out in the normal grass that needs to be addressed by subsequent treatment. And so the thing we don't want to do with surgery is cause a neurologic deficit that will make that subsequent definitive treatment less likely to be effective. So those are some of the things that I think about with surgery. Alex, any comments on this before we move to kind of the histology and the diagnosis and stuff like that?
Yeah, we kind of answered most of my questions, but one that I had is there any role in CSF cytology in trying to diagnose these? I'll let you answer that one first.
Yeah, really important question. So the answer is no. Do not hold up your biopsy for CSF or CSF cytology. Very few of any of the brain lesions will have infiltrated into the spinal fluid. But every rule was meant to be broken. And so you're going to remember that rule. Don't hold up the biopsy for CSF, except in one specific patient population, and that's our CNS lymphoma patients. And not every CNS lymphoma patient. It's really those immunocompromised CNS lymphoma patients. And they're going to show up a little bit differently than typical CNS lymphoma. Typical CNS lymphoma is a single, homogeneously enhancing big lesion. So white matter lesion is homogeneously enhancing and it's single. And that's a typical CNS lymphoma, except in immunocompromised patients. Immunocompromised patients break all those rules. So it's multiple lesions. They're ring enhancing and they're often smaller. They're kind of distributed throughout the brain. And so those patients, we can actually make a diagnosis with CSF alone and avoid a biopsy. So that's the one case to consider that, but typically we would go right to biopsy.
Got it. And one question from the audience would be, how is the role of advanced MRI techniques like perfusion-weighted imaging and diffusion tensor imaging evolved in the grading and diagnosis of gliomas?
I love this question because we want better imaging. We need better imaging. We love perfusion and diffusion and BSC and all of these sorts of things to change glioma care. And sometimes we do use them, but they have a limited role in true characterization, in diagnosis or prognostication. In the future, we may have IDH mutant scans. We may have additional perfusion sequences that can guide us. But today, those imaging procedures have about a 50-50, 60-40 ability to kind of lean us in one way or the other. And so biopsy and tissue does remain the gold standard for establishing both diagnosis and prognosis.
I've got a quick question for you, Dr. Strowd.
Yeah.
In a patient who presents with symptoms and imaging that's very typical of a low-grade glioma and progression that follows that, how aggressive would you be at getting the tissue and biopsying? And is there any risk associated with doing a biopsy on a low-grade glioma for like a transformation to a higher grade, for example?
This is a great question because, I think the landscape is changing here. The times are changing for these low-grade gliomas. If we get to the end of the lecture, I'll talk about some new data with IDH inhibitors that can be used early for these low-grade gliomas. Historically, there were some low-grade gliomas we waited and watched and avoided biopsy, for concerns, of side effects or risk. That's pretty rare today. So today, a small biopsy for a minimal amount of tissue can guide decision-making greatly with molecular characterization. So I really send all glioma patients for at least a biopsy to molecularly characterize that. The one exception is brainstem gliomas. And I have several brainstem glioma patients that we've treated without biopsy. We've looked at CSF circulating tumor DNA and kind of characterization of the CSF as an exploratory experimental approach. And in the end, have treated some of those patients based on imaging diagnosis alone because of the risk of biopsy. And that's a multidisciplinary discussion where we're involving surgery and radiation, radiology pretty early. But these days, biopsy as a one-night hospital stay can be done safely. And because we can molecularly characterize, test the genes, and that can guide what we do, it is very important to have that information. Great questions. All right, well, I'm going to proceed forward, keep running them through in the Q&A, and we'll cover them. I'm going to go through this next part a little quickly, and it's going to feel more quick than you want, and so you can slow me down. I don't need you to understand all the histology or the molecular characterization, but I want you to have heard some words, take some snapshots, and kind of come back to some of this information as we go through. So how do we make a diagnosis? There's 3 steps. The first is histology. That means looking at the tumor under the microscope. And this used to be all we would do. And we'd make a diagnosis of astrocytoma, oligodendroglioma, ependymoma based on histology alone. And these were the 3 diagnoses. That's just what they were. Astrocytomas were these small little, dysmorphic tumor cells. Oligodendrogliomas had this fried egg appearance with a haloing around, the central kind of dark, area of tumor cell. And ependymomas are these sheets of ependymal cells with varying rosettes. And that's kind of what we did. And you may want to go back and look at what some of those histologic features are. I don't need you to know these things in detail, but, you can come back to this later and kind of take a look at it. There's some histologic features of grade 1 tumors, those Rosenthal fibers, eosinophilic granular bodies are things we test neuro-oncology fellows on. Grade 2 tumors are infiltrating. They're not well circumscribed in the brain. They're infiltrating. They're out in the brain. They're hypercellular. There's some nuclear atypia, but they look really like normal brain. And so that tends to be the feature of grade 2. Under the microscope, grade 3 tumors are more aggressive. They're not just are they infiltrating, but they are dividing. There's mitotic figures, and we can see proliferation with a Ki-67 index that measures proliferation. And then with grade 4, you do need to know this. So let's pause. Let's know these 2 things. Increased vascular proliferation and pseudopalissading necrosis are the diagnostic hallmarks of a grade 4 glioblastoma. So that's what we can really determine with histology. But today, histology really leaves us lacking. And the molecular characterization, the genetics, the markers are what really guide us. So initially, the patient has their surgery, we get the histology back, and it gives us a ballpark estimate of what we're dealing with. It looks like a glioma, we're in that category, and then we wait for some gene testing to come back. There are 3 genes that I want you to know about. I want you to know about IDH, 1p19q, and MGMT. So know this slide, take a picture of it, kind of put this down in your mind. I'm going to show you another one on the next slide that you don't need to know. IDH is the most important mutation to characterize in a glioma. There are IDH mutant tumors and IDH wild type tumors. On the slide, it says IDH 1 and 2, but you're just going to group those together and say it's either IDH mutant or it's IDH wild type. IDH mutant gliomas are the low-grade diffuse gliomas. Low-grade diffuse gliomas are IDH mutant tumors. Now, sometimes they turn into high grade, but that's what they are. That's how they're characterized, and that's how you're going to remember those. IDH wild type tumors are glioblastomas, and glioblastomas are IDH wild type. And there are a couple of variations in that, but I want you to draw a clear distinction in how we use that gene and how it guides us with diagnosis. That's important. The second thing is this 1p19q codeletion. 1p is the p arm of chromosome 1, and 19q is the q arm of chromosome 19. And if there is a whole loss, an entire loss of those arms of those chromosomes, we call that 1p19q codeletion. And this is an important diagnostic hallmark of oligodendrogliomas. Oligodendrogliomas have this 1p19q codeletion, and that's what you want to know. And this is really, really important because people live a long time when treated optimally for an oligodendroglioma. And so this is really, really important. The last is MGMT. MGMT is a DNA repair enzyme. And it's important. It's uncommon. It's only seen in 30% of glioblastomas, more common in lower grade gliomas. For glioblastomas, it's uncommon, but it has really important treatment implications. It is a predictive biomarker. It predicts response to chemo, and that's how we use it. There's some other genes that you may want to search and look up and kind of think about if you're interested in neuro-oncology. ATRX and CDKN2AB and CIC and TERT and EGFR and gain of chromosome 7, loss of chromosome 10. I don't need you to know about these things. I want you to know of them and then be able to come back and kind of look at those, in your future. And then ultimately, we pull the histology, the molecular markers into a final integrated diagnosis. So I'm going to show you 2 slides that are dizzying, but you can come back to them. And it just gives you an idea, a flavor of how we use this information. So our diffuse gliomas are either IDH mutant or IDH wild type, and we use that to determine ultimately whether it's an oligodendroglioma in this blue color, the astrocytoma in like yellow and orange, or a glioblastoma in red. And those genes help to guide us to that ultimate diagnosis. And we can use the histology and we can combine that with the genes, but ultimately we're coming up with this final row of an integrated diagnosis, bringing the genes and the histology together. This is another way of looking at that. It says that everything that's IDH wild type is red. Those patients don't do as well. We need more aggressive treatment, and everything that's IDH mutant is kind of blue. All right, I'm going to quickly go through in just a couple of minutes radiation and chemotherapy. There's a few things I want you to know about radiation. There are 3 types of radiation: stereotactic radiosurgery, partial brain radiation, and whole brain radiation. Those are the 3 types. For gliomas, we use partial brain radiation because we treat a high dose to a central area, and there's a fall-off margin of tumor we can't see that we want to treat. For brain metastasis, we either use stereotactic radiosurgery or whole brain. And this is what this kind of looks like. So here's a whole brain field. We're treating all of this area here in green, and we're not treating the face. This is very quick to plan and easy to do for patients with tumors all over the brain, like a brain metastasis patient. That's different from a glioma radiation field where the highest dose is delivered to the enhancing tumor, which is in red. There's a dose that's therapeutic. That's a large dose delivered to the non-enhancing tumor that's here in this lighter red. And then there's a fall-off dose delivered to other areas of the brain where there may be infiltrating tumor. And that difference from stereotactic radiosurgery, where there's the rapid fall-off. The dose is delivered primarily to the tumor, which is this red line here, with not a lot of dose delivered to the area of the brain around it, which is what we want in a brain metastasis patient. Chemo. For chemo, we think about hot sauce. Not every person likes hot sauce, but some people love it and they just dump it on their food. Not every tumor is going to respond to chemo, but those tumors that respond extremely well. And over time, we've learned how to give chemo in a way to improve survival. So go to 4 months survival up to 20 months as we've learned how to better deliver chemo. And this is what I want you to know. There's a couple of chemo regimens, PCV and Temodar, and we give them differently. And we treat oligodendrogliomas different from astrocytomas, different from glioblastoma, and we tend to use 2 chemotherapy regimens. And so I want you to just know about what those are, and you can explore in the future kind of how those are given. The 2 regimens are Temodar and PCV. Temodar is oral, PCV is a combination, and they tend to be well-tolerated chemotherapies that work in some patients, and we tend to give them in all because it's hard to select who's going to respond the best to those treatments. All right, in the last minute, because I know we're getting a little bit low on time and I want to get to your questions, I want to excite you about some fun and exciting things that are going on. So, Alex, maybe we do like rapid fire on a case and an exciting advance in glioma in kind of, 3 minutes or less, and excite these folks on some of the stuff going on in our field. So I'm going to turn it to you with kind of case 1.
Sounds good. Case 1, 65-year-old with left temporal glioblastoma, IDH wild type, MGMT promoter, unmethylated, presents to clinic after completing radiation therapy and temozolomide. MRI brain with and without shows stable findings. You discuss adjuvant temozolomide, and he is interested in adding a new treatment that he has heard about called Optune.
So this is great. We didn't talk about this. We talked about everything on the slide. We're synthesizing what you just learned and adding this additional treatment. So the latest treatment to be approved, and I just want you to know what this is called Optune. It's not a surgery. It's not a radiation. It's not a chemo. It's a device. And it delivers an electrical field, a tumor treating field, this alternating electrical field. It looks similar to an EEG cap. Those epileptologists know, I know what that is. It looks like EEG electrodes. But instead of sensing the electrical activity in the brain, this is delivering an electrical activity that prevents microtubule formation and cell division. And so this is something you'll see on some of these glioma patients, particularly glioblastoma patients, and it is the newest treatment to be out there. It's very safe. It can have a quality of life impact for our patients and is being incorporated into their care. So a new advance and kind of a new modality of how we treat.
All right, case 2, 25-year-old presents for evaluation of progressive bilateral hearing loss. He has a history of multiple meningiomas, a non-enhancing spinal cord lesion, and bilateral vestibular schwannomas. He's been told that radiation therapy is an option, but surgery is high risk given the bilateral and multifocal tumors. He is interested in a new treatment option.
What is the new treatment for NF2 that we're excited about, that we just love to give because it really helps to avoid surgery and radiation? That is a treatment called bevacizumab. I'd like you to just know about this. This is a treatment we have. These NF2 patients, we looked at them in the beginning, have multifocal tumors. We can't do surgery. Radiation can cause cancer in this tumor predisposition syndrome, and bevacizumab is changing the lives of these patients. Over 55% of patients will have an imaging response. Yellow will go to red. More importantly, 57% of patients will have improvement in hearing. This is something to know about. There's never been a treatment to really help rescue function in these patients, and we now have it and use it frequently. So neat new treatment.
All right, case 3, 21-year-old with a history of cafe au lait macules, axillary and inguinal freckling, and an optic pathway glioma that did not require previous treatment, presents for a left leg mass with pain and slowly worsening mild left leg weakness and reduced hip extension and knee extension. Patient has seen surgery who indicated that surgery is not an option and is interested if there are any alternative approaches.
There is learning all over this slide. This is a great case of NF1. And neurofibromatosis type 1 is that NF that causes neurofibromas, plexiform neurofibromas, which was what we're hearing about with this patient. There's a really exciting new treatment called selumetinib. It's a MEK inhibitor. It works to treat the plexiform neurofibromas, not the cutaneous neurofibromas, not the cafe au lait macules, but these large plexiform neurofibromas that really diffusely infiltrate into all parts of tissue and lengthen the leg and lengthen the amount of body that exists. And this oral drug has really resulted in dramatic improvement. 70% of patients, of children put on this, can have improvement in these tumors. So a neat thing to think about as a new therapeutic intervention. All right, last case quickly, Alex. I love this case.
Yep, last case, 65-year-old with a history of renal mass lesions presents for follow-up evaluation of a multiple slowly enlarging spinal cord enhancing masses and several multifocal cerebellar enhancing tumors. She's undergone multiple rounds of radiation therapy and surgery, suffered bilateral blindness since early in life due to retinal hemangioblastomas. She's interested in an option for treatment of her multifocal tumors.
This is a patient I saw 10 months ago, and you're going to see these patients as a neurologist, and you're going to see patients that have, other areas of disease and need to know what this is. This is von Hippel-Lindau, a cancer predisposition syndrome. And I want you to know about this medicine, brand new. Few people will know about it, but really changing the lives of these patients. And it's called belzutifan. It's a HIF2 alpha inhibitor, and we don't have time to get into the cool science, but it's the first ever medicine to treat all types of tumors in von Hippel-Lindau, including their brain tumors, and including to avoid radiation and surgery and potentially to treat symptoms in these patients, and can have a dramatic response. I mean, here you're looking at imaging response in these patients, a vast majority of patients able to see benefit, changing their lives. And the last thing I want to cite you with is something brand new. It just happened a month ago. This is a new medicine, vorasidenib. It's an IDH inhibitor that was used to treat low-grade glioma patients. And what you're looking at here is the progression-free survival, the time to when that tumor progressed. And if they had no treatment, they progressed at 11 months, and with treatment out to 27 months. And even more importantly, the time to next intervention, the next treatment, went from 17 months to just not even needing a treatment on this medicine. So things are changing in neuro-oncology. It's really important to know about it as a resident and as a neurologist. And I hope it also excites you to think about our field, for your future. So we ran up to time just a little bit. Thank you for listening. I'm going to stop the share and happy to answer questions for those that can stay on or follow up with those that can't. Thank you for your engagement.
Looks like we have one leftover question in the chat that you might be able to get to. Which tumor types have the highest risk of angiogenesis? And if the tumor is near a major blood vessel, what is the risk for vascular invasion?
Yeah, great question. So there's two ways to think about this. Historically, embolization was done for large meningiomas that where there was thought to be a high risk of bleeding intraoperatively, particularly those parasagittal ones right next to the venous sinus. That's not done a lot anymore. It is done in selected circumstances, but meningiomas are avidly enhancing. Those were those really avidly enhancing lesions. So there is a vascular component, and that's why the bevacizumab we talked about is an anti-vascular agent. So we target angiogenesis, in those tumors. The highest risk for angiogenesis is really seen in glioblastoma. It's rapidly developing. There's new blood vessel formation, and a bevacizumab, that anti-VEGF, anti-vascular agent, is approved, for treating that. Unfortunately, tumors figure out how to grow even without blood vessels. So shutting down blood vessel formation with bevacizumab doesn't improve survival, though it improves the quality of life and how those patients do. And so we're still figuring out how to target the angiogenic or vasculogenic component of gliomas. It's a part of a lot of these tumors, but isn't a driver that is targetable or therapeutically intervenable in many of our patients.
And just
I like the way to go, Alex. Good question or statement for that one.
Best question of the day. For the day-to-day life of the neuro-oncologist, I know you mentioned that obviously oncology is a team approach. Is your role largely to replace the medical oncologist in patients with exclusive brain tumors, or is it a supplementary role? Do these patients often have both a medical oncologist and a neuro-oncologist on their team?
It's a really great question and a tough one to answer. It depends on the patient. For a brain metastasis or leptomeningeal disease patient, I am assisting and working alongside a medical oncologist to manage those patients. They are the primary driver, and we are, there to support the brain-specific management of those patients. And that's fun and exciting, to work alongside those experts and share new treatment approaches and those things. For the glioma patients in my practice, I'm the primary driver. I really am the, neuro-oncologist, medical oncologist. I am that oncology specific home for those patients. And so that varies by provider, that varies by practice, and that varies by patient, kind of what that role is. And it means that every day is different for me, kind of what I'm doing with patients and what my role is. It's a lot of collaboration and a lot of, work along the multidisciplinary team. So if that's what you like to do, communicate well, play with teams, and those things, neuro-oncology is definitely something to do. And I love Ben's reminder. So for those still on, if we didn't get to your question, or you think about something, bring that to the webinar. Dr. Mohile is one of the most phenomenal neuro-oncologists, in the country. Lauren Schaff is just a premier neuro-oncologist, an expert in CNS lymphoma. They're going to have two great cases to talk a little bit more about what you learned today and apply it. I think that's what's great about the NeuroPanels, is see how the experts kind of, approach these cases and apply this information.
Wonderful. Thank you, Dr. Strowd. Thank you, Dr. Gerhardstein. Of course, thank you, Dr. Weber, for everything that you've done today. Thank you, audience members, for the great questions. Again, all of these webinars are posted on our YouTube channel. So if you need to review or you didn't take enough snapshots, that will be available to you. Again, thank you so much for joining the AAN for the Virtual Resident Education Lecture Series. Have a good day, everyone.